Good day, everyone. My name is Linda Weiner, and I'll be the moderator for this webinar. Thank you for joining us. With us today, we have two amazing researchers and clinicians and publishers and in the field. We have with us Dr. Irwin Goldstein, who will speak on orgasmic anhedonia. And we have Jim Pfaus, who will speak on post-orgasmic illness syndrome. Just to tell you a little about me, I am a licensed clinical social worker who's been working as a sex therapist and educator in the field for about 40 years, and was one of the original staff members at Masters and Johnson Institute. I see couples and do webinars, and I'm very interested in the combination of working with sexual health professionals, researchers, and clinicians, because I do see this work as involving many different disciplines to be our best selves. I want to read a little bit about Dr. Goldstein, who has experience since the 1970s in this field. He's authored many articles. He has worked in the field as director of sexual medicine at Alvarado Hospital. He's a clinical professor of surgery at UC California, San Diego, and practices medicine at the San Diego Medicine Sexual Medicine Institute. He's been editor-in-chief of Sexual Medicine Reviews, past editor of the Journal of Sexual Medicine, and past president of many of our esteemed associations, including the International Association for the Study of Women's Sexual Health and the Sexual Medicine Society of North America. He holds a degree in engineering from Brown University and received his medical degree from McGill. The World Association for Sexual Health and several other organizations have honored him with awards for his contributions, and they are many. Jim Pfaus is a basic preclinical research in behavioral neuroscience and neuroendocrinology with a focus on neurobiology, neurochemistry, molecular biology of sexual behavior. His research examines how the brain's neurochemical and neuroanatomical systems are organized for sexual arousal, desire, pleasure, and inhibition. He's also interested in the role played by stimuli associated with sexual reward in priming sexual responses, and his research has revealed a strong epigenetic effect of experience with sexual pleasure. His laboratory has also played a major role in a preclinical development of drugs to treat sexual arousal and desire disorders. Research from his lab has been reported worldwide, and he's appeared on many public channels, including HBO and BBC. Welcome, everyone. Today, what we will be doing is having presentations from our two speakers, about 20 minutes each, and then that'll be followed by a Q&A of about 30 minutes. And we encourage you to press the Q&A button and to submit your questions, which will be discussed in the 30 minutes that follows the presentations. We thank you so much for joining us today.
Thank you, Linda. It's my honor and privilege to be here. It's 6 a.m. in beautiful San Diego, so it's kind of early to discuss orgasm, but that is our job. I want to say hi to Jim Pfaus. We love Jim. I'm from Montreal, and he's from Montreal, and we love our Canadian hockey team. I want to say thank you to Linda for the introduction. I want to say thank you for Siobhan. She's not here, but she corralled us so we could all do this. And thank you, Lillian, for taking her place. ISSWISH is the largest society for the study of women's sexual health in terms of study, diagnosis, and treatment. And they have put together or assembled a orgasm consensus panel, and we're going to talk about the findings. There's 22 experts on this panel. No, okay, you can do this. There's 22 experts on this panel, and they're multidisciplinary. One of the pathophysiologies of FOD, female orgasm disorder, is the anhedonia, which we're going to talk about. Keep that slide there. Pleasure is a feeling. It's a experience. It's a satisfaction, satiety, contentment, enjoyment. It feels good. It feels positive. It's something that we seek. It's the opposite would be aversion, which is something that we feel bad and don't. I just want to say that if you're expecting me to provide you with a million strategies how to treat your patients with anhedonia, not going to happen. We're at the point of knowledge of the anhedonic orgasm FOD as we were in the early 2000s with PGAD. But we're talking about it, and talking allows us to gain knowledge. And Jim and I are speaking among all the other panelists to get this. So today I'm going to talk about the physiology of orgasm. We're going to talk about the intense brain activity during orgasm, this positive feedback of excitation leading to inhibition increases, which increases in excitation with increases inhibition. We're going to talk about the Fawcett model. We're going to talk about that orgasm is preceded by arousal and terminated by resolution. We're going to talk about our definition. We're going to talk about pleasure and why we seek it. We're going to talk about the neurochemicals released during pleasure, and that's how I'll link with Jim. And then we're going to talk about some take-home messages and some therapeutic options for you. I'm going to give you a slide. You should take a photo of where expert opinions have agreed this could help in these group of patients with FOD from the anhedonia. And what else we're going to talk about is the future, because the future is going to be the new era of psychedelic drugs, I believe, are going to be the way we're going to manage all this. Okay, that's the prelim. Let's do the next slide, please. Okay, so among all the things that happen in your body, there is nothing, I believe, and Barry will support me on this, there's nothing more intense brain activity related than having orgasm. And if you look at, I don't know if you can see my pointer, but if you can't, doesn't matter. On the right slide, you could see it says 80 Brodmann regions. There's actually 120 or so Brodmann regions. There's internal and external. These are the external. You can see that virtually all of the Brodmann regions increase brain activity. Remember, it's a hot metal rod, so white is the hottest you can make metal. So where you see white, that's the hot. Next slide. So this is where red color is significant activity over baseline. You can see the top row, there's not much red, but as you get towards orgasm, you get a lot of red, and then when you recover. So there's a phase, if you like, that precedes orgasm, then there's orgasm, then there's a recovery phase or a resolution phase. Next slide. So the next slide will show, when we get to the next slide, a video. I don't know how you run a video on this thing, but there you go. Oh, perfect. Okay. So it's a 2-minute video, and I could talk through. This is, remember, orgasm is this phase where excitation is at its peak, and the climax is when the peak triggers the inactivation. And if you just go through a yawn, if everybody wants to yawn, it's so early in the morning here in San Diego, yawning is probably very appropriate. Go through a yawn. Watch me. And then when you reach the point of muscle tension, relaxing, there's your pleasure. So as we're increasing, this is the activity. You can start to see white forming as the brain activity increases. And then as you get to significant white, you're going to here. Now this person is about to enter the point of excitation of no return, where it then activates the deactivation, causing the muscle relaxation. It's the loss of muscle tension, which is the pleasure satiety. Okay, there you go. Now this person is having the orgasm. It's amazing. Almost every brain region lights up. And then that's the end. Okay, so go to the next slide. So just to point out, you can read the box, research suggests regular sexual activity, positive impact on cognitive health, including potentially reducing dementia risk. It's because there's so many goddamn brain parts of the body activated during orgasm. let's argue that brain blood flow is good for the brain. We're all in sexual medicine. Let's say that those who have lots of orgasms are providing a state of amazing blood flow to the brain. So do that as often as you think is appropriate, it would be my suggestion. Next slide. Okay, so this is the positive feedback, which is, I don't know, Michael Perlman, you're still on, but, Michael discusses the seesaw where one goes up and one goes down. And what I want to suggest is that during orgasm, as excitation increases, in order to avoid the pain of the increased activity during physiological arousal and cognitive excitement, you have to have increased inhibition. So this little experiment is you put your finger on a pointy thing and you increase the weight applied and it causes pain. But as you increase arousal, which is where you can see the item in the vagina, as you increase arousal, you increase the threshold for having pain. You could practice that on yourself. Put something pointy on your finger and get sexually aroused. You'll find you won't feel the pain on your finger the more you get sexually aroused. It's kind of a fascinating experiment, but it is true. During the process of achieving orgasm, where you get to the point of no return on excitement, the only way to do that is as you increase excitation is to increase inhibition. Next slide. So in a graphic demonstration, this is increasing arousal. So the sort of brain spinal cord depictions are showing increased myotonia at the bottom, genital and non-genital stimulation, increasing arousal, but increasing inhibition. And that allows you to climb without having the aversion. Remember, pleasure at the end of the day is something that you want to have. You seek it. Where pleasure happens is where you start the deactivation. So you reach the point of arousal that's the reddest kind of light bulby looking thing. The myotonia is at its peak. I'll go through the yawn again. When you get to the point where the yawn reaches its maximum myotonia or muscle tension, when you relax that actually feels good, which I'm going to do it again one day. And then you resolve you end the orgasm with a resolution phase. So go to the next slide. And this I love this slide. It's my favorite slide on earth. You can't follow this, but let's go to the upper left. You're providing excitation through the genital somatic system. That's like touching. Remember, we're focused on women because we're an ISSWISH, and this is an ISSWISH slide, but it obviously would account for men as well. There's a genital somatic excitation of increased sensation. Then there's a genital visceral, which would be inside the vagina and the G zone area. And then there is the nipple, which is vagus. And then there are the toes, which is non-genital somatic. And then the vagus nerve. So in your ear, there's the cymba concha, which is providing sensation. And then you have the serotonergic pathway. So we're up on the top line. As you sort of stay to the second line on the right, you can see the paracentral lobule, which is where the genitals are all related. And if you look carefully, you can see the toe, the cymba concha, and the nipple are the same as the clitoris, the vagina, and the cervix. They're all at the paracentral lobule. So that would be where the prime excitation for genitals is. And then there's the sympathetic system involving a positive feedback with the parasympathetic system. And that hardly ever happens in the body. When you activate sympathetic, you typically deactivate parasympathetic. But with this, both happen. And a good example is the bottommost row on the left. You see the pupils. The pupils dilate. That's a sympathetic response. But then you tear during sexual activity. That's a parasympathetic response. And as you open the lowest row on your tongue, you get increased salivation, which is sympathetic, but increased liquid, which is parasympathetic of the salivation. Then you activate through the sympathetic system the adrenal gland. So there's a hormonal contribution. And the sympathetic system makes the nipples erect. And then you have oxytocin and dopamine. And then you have muscle tension, and you have it in your face. And you make a faces as if you're having pain, but you're actually having pleasure. It's this amazing, amazing experience the time prior to orgasm, which is physiological arousal and cognitive excitement, is truly one of the most fascinating events in human physiology. There's just so much going on. Heart rate increasing, blood pressure increasing, lubrications coming out of where, nipples erecting, eyes dilating. I love it. All right, next slide. So, at least from the genital point of view, the relevant nerves, so you can get anhedonia, obviously, with neurologic issue problems. So let's at least study the nerves. On the far left is a column called nerve. So there's the somatic pudendal, sensory motor. There's the pelvic, so inside an organ like the rectum or the vagina or urethra or bladder. Those are afferent, visceral afferent issues. And then the sciatic nerve also goes to the paracentral lobule. And then the hypogastric nerve is the sympathetic version of turning things off in general. Like as you arouse, you can't activate your bladder, and then your bladder fills, and that will participate in the squirt, which we'll get into at some point. And then the vagus nerve is this amazing nerve that doesn't go into the spinal system, but ends up in the brain in the retroperitoneum. So lots of cool things that are happening and that are involved in orgasm. Next slide. All right, so another way to look at them, at least from the genital region, is this. So the black nerve is the pelvic nerve. The blue nerve is the pudendal nerve, which is, at least from the sensory point of view, between the pubic bone to the anus. It's all the sensation there. The green nerve is the hypogastric nerve. The red nerve is the vagus nerve. And all of those nerves are involved in the genital physiologic arousal event happening just before you reach that peak, that climax of orgasm. Next slide. All right, so now we've reached the point of no return. We're at orgasm. Let's just read it. The orgasm is where you have a peak of excitation that actually can't go any more excitation, so it triggers inhibition, and you get that relaxation of the muscle tension. It's the relaxation of the muscle tension that is the pleasure that ends with satiety and contentment. And then orgasm can be associated with concomitant fluid or ejaculation's release. Next slide. So we're at a point of defining orgasm, our ISSWISH consensus panel. This is one of our earlier iterations. We now have even more iterations. But at the end of the day, it's during sexual activity, it's a sensory motor experience with variable levels of intensity and pleasure. I'm marking pleasure in yellow because that's our topic. There's before orgasm physiologic arousal. It's generated by repetitive genital and non-genital stimulation. There's awareness of physiologic and cognitive arousal and muscle tension. So it's the three things. It's the physiologic arousal, cognitive excitement, and muscle tension. So those are the three things that are happening. And then you reach a point of no return. That's the climax where you can't excite anymore. You trigger the deactivation. The deactivation is characterized by muscle relaxation that gives you the satiety and contentment. You can continue the stimulation and get further orgasms. Orgasm may be accompanied by release of fluids, ejaculation, and then there's the phase where the orgasm has ended, and that's the resolution and its baseline pre-arousal. And Jim will be talking about the post-orgasm illness phase, which is the post-orgasm illness syndrome is in that phase. The anhedonic situation is in the orgasm phase and can be explained in part by problems in the pre-orgasm or arousal phase. So the context of making a definition where there's relevance to the clinical perspective is what we're trying to generate with the ISSWISH panel. Next slide. All right, so 3 slides on pleasure. Pleasure of orgasm, it's widely intense, it's non-aversive, it's generated by genital and non-genital stimulation, and the key is the muscle tension. When you yawn, when you sneeze, when you do anything that's kind of a non-orgasmic orgasm, I mean a non-genital orgasm, It's muscle tension that's generated and released. And that's the concept that activation of neurons is essential for their survival. So sensation of sensory activity is therefore beneficial to the individual. Next slide. And overt behavior generates sensory stimulation and is repeated if it's not detrimental to the individual. So sensory stimulation that is beneficial and therefore repeated is pleasure. If sensory stimulation is detrimental, you're not going to repeat it. It's aversive. Intense sensory activity that is not aversive is perceived as intense pleasure, and orgasm exemplifies this process. Next slide. This is our last slide on the pleasure. Awareness of any and all sensory stimulation that is not aversive is what we perceive as pleasure. Much of our daily sensory stimulation is so pervasive that we are habituated to it, sitting, seeing, hearing. We don't have orgasm every minute, so it's not like we're habituated to it. If we lost any such stimulation for years and suddenly restored, like you haven't sat for years, now you sit again, that would be pleasurable. Hence, sensory stimulation novelty is an essential component of pleasure. Of course, higher cognitive processes, appreciation of the meaning of the sensory stimulation influences the quality of the pleasure. Okay, the next slides are the neurotransmitter slides. There's serotonin increase from the dorsal raphe nucleus has been associated with anorgasmy. Reduced dopamine levels are implicated in anhedonic orgasm. Next slide. There's opioids, endocannabinoids, self-reported cannabis use associated with increased orgasmic pleasure in acute but not chronic use, and there are specific endocannabinoids that contribute to pleasure. Next slide. And then there's the endorphins, opioids, which are released. And Jim is the more the dude on this stuff, and Jim could talk about this. But these are all the things that are happening internally. And that's where psychedelic drugs may play a role in the true treatment of the anhedonic orgasm. Next slide. Okay, so in summary, orgasmic satiation and pleasure associated with a whole bunch of neurotransmitter changes in the brain at the time of the excitation being at its peak, just about to trigger. There's all of these neurotransmitters happening. Next slide. Okay, so I'm going to make it now practical for the last few minutes of my talk. On the upper left is the normal orgasm, so it's increasing. So excitation is red, inhibition is blue. So excitation, inhibition increasing, you get to orgasm, you have multiple orgasms. FOD1 is when you can't get to the peak, you'll get to some level of the arousal, but you don't get to a peak, so you don't enter climax. Number two, you don't enter climax because it's aversive. Number three is the premature, sort of early muted orgasms. Number four is what we're going to talk about, the anhedonic one, where at the time of peak, you're inhibiting the peak, so you're not getting to the pleasure. And Jim is going to talk about number five, the post-orgasm illness. So next slide, that's going to focus on what we're going to talk about today, the anhedonic orgasm. Next slide. And this is the take-home slide. If you want to take pictures of this, this is what we have used, expert opinion on how we can treat the individuals who have anhedonic orgasms. The column on the left is the CNS stimulation one, the dopamine one, dopamine, norepinephrine, oxytocin, serotonin antagonism, testosterone, PD5 inhibitors, and arousal gels. There are 8 categories, and then the medications, and then the next column is the dosages and when to administrate them. I have had patients with orgasmic anhedonia, I would see tons of them, get better with a group of these, taking several of them, like doing, my favorite one is dextroamphetamine and amphetamine mixed salts, help people focus. We then use the subcutaneous injecting bremelanotide along with maybe cabergoline. We add bupropion, oxytocin, buspirone, fulvancerin, testosterone. We add these in multiple ways to try to get people to get through the climax and get to release of the muscle tension, which is going to give them the pleasure. So this is expert opinion. These are not fully consensed yet. And I just need to share that there's better choices one day when we get to the psychedelic versions of these things. like ketamine and other items. Next slide. I'm ending. I'm way over the time. It's just that we have an ISSWISH orgasm consensus panel. It's allowing us to have communication. We're doing orgasmic anhedonia as one of several FODs. This is all off-label. It's all based on expert opinion. If you're ever going to prescribe something, please read the package insert for adverse events, toxicity, drug interactions, contraindications, potential for abuse, and other safety information. My last slide is the next one. Orgasms are considered as the peak of a sexual experience. The entitlement to pleasure and orgasm is highly cultural. The major contributor to the pleasure of orgasm is sensory awareness of the genital and non-genital stimulation. There's an intense proprioceptive response to the muscle tension. Its subsequent resolution is what pleasure is. God bless you. Jim, the show is yours.
Thank you so much, Irwin.
Thanks, Irwin. Okay, so I'm going to talk about post-orgasmic illness syndrome. Next slide. These are my disclosures. Next slide. So what is POIS or POIS? It's a condition in which a person develops flu-like fatigue and/or allergy symptoms after ejaculation and orgasm, usually in men, but we're seeing more in women, whether with a partner, through masturbation, or even spontaneously during sleep. Among its distinguishing characteristics are rapid onset of symptoms after ejaculation or orgasm, the presence of an overwhelming systemic reaction that involves multiple systems, and the symptoms usually begin within 30 minutes of ejaculation or orgasm, so it's pretty quick, but it can last for several days before dissipating, as if you've got a cold. There's a primary type. The onset occurs during puberty and with the first experience of ejaculations, and a secondary type, which is more common, with an onset later in life. Some POIS sufferers report lifelong rapid or premature ejaculation with intravaginal ejaculation latency times of less than 1 minute. Okay, next slide. There's no agreed upon diagnostic criteria, and I put yet because as like with PGAD and other new things that are seen in the clinic, these are becoming more and more obvious to people as more and more information is out there. Marcel Waldinger, recently deceased, had one or more of the following symptoms: sensation of flu-like state, extreme fatigue or exhaustion, weakness of the musculature, experiences of fever or perspiration, mood disturbances and or irritability, memory difficulties, concentration problems, incoherent speech, nasal congestion, watery nose, itchy eyes. All the symptoms occur immediately or within seconds or minutes after orgasm or ejaculation, which is initiated by coitus, masturbation, or even during sleep. Symptoms can occur always or nearly always within more than 90% of ejaculatory events, or in one particular ejaculatory setting, i.e. with a partner, only with masturbation, or during nocturnal emissions. Most of the symptoms last between 2 to 7 days, and they disappear spontaneously. Now, the syndrome is considered at this point rare. The actual prevalence is unknown, but if you look at the POIS Reddit group that was founded in 2015, it now has more than 4,800 members, largely from North America and Europe, and most are male. Next slide. Next slide. There are 8 clusters of symptoms if we take Marcel Waldinger's criteria into consideration. So there's a general cluster: fatigue, exhaustion, palpitations, problems finding words, incoherent speech, dysarthria, which is a lack of motor control of the tongue, leading to slurred speech, concentration difficulties, you're quickly irritated, can't stand noise, photophobia, you become depressed, you have an anxious mood, perhaps sometimes with accompanying suicidal ideation. You can have flu-like cluster: fever, perspiration, shivers, flu or cold-like symptoms. Head symptoms: headache, foggy or heavy feeling in the head. Eyes sometimes get burning, red injected eyes, blurred vision, watery, irritating, itchy eyes, painful eyes. You can have rhinitis in the nose, congestion, watery, runny nose, sneezing. And again, this lasts for days. Throat: so you can have a dirty taste in the mouth, dry mouth, sore throat, tickling cough, hoarse voice. Muscle tension behind the neck, so almost the onset of symptoms of a cold. Muscle weakness, pain in the muscles, heavy legs, stiff muscles, and skin. Sometimes people get hives, blotchy red patches, or itchiness. This can also include exacerbation of inflammation, including gut inflammation of irritable bowel syndrome. POIS is likely underreported and prone to being erroneously described to psychological factors, i.e. hypochondriasis, somatic symptoms disorder, etc. Next slide. Well, let thy symptoms be thy guide. All the symptoms point to some kind of hyperinflammatory allergic response that occurs after ejaculation or orgasm. Some describe it as an anaphylaxis or cytokine storm. What could cause this? Next. Histamine. Next slide. Well, Irwin has already pointed out the substances released at orgasm, among which are endogenous opioids like beta-endorphin, which kind of produces the ecstatic euphoric pleasure of orgasm, your sensory awareness of that. Serotonin, right, released from neurons that are projecting from the dorsal raphe to cortical limbic hypothalamic structures. They oppose dopamine action. They produce satiety, the calm, the kind of refractoriness after orgasm. But the other biggie that's released is histamine, released from mast cells, leukocytes, hypothalamic tuberomammillary neurons that, of course, go to the pituitary. They cause vasodilation and a decrease in blood pressure, which you get after orgasm. But histamine binding to endothelial cells also causes them to contract, which then increases vascular movement. So from erection to then de-erection, the movement of blood back from the external tissues back into the core. It stimulates the synthesis and release of various vascular smooth muscle cell relaxants, such as nitric oxide, endothelium-derived hyperpolarizing factors, etc., that result in blood vessel dilation, so the movement, again, from blood from the periphery, from the genitals, back to the core, which is detumescence. But histamine plays a key role in the pathophysiology of anaphylaxis. Next slide. Well, major histamine-producing cells in the body, mast cells, basophils, the ECL cells, which are in the gut, and histamine neurons. There are also minor histamine-producing cells that you have T cells, macrophages, neurophiles, epithelial cells. Next slide. This is a mast cell. That's what it looks like. It releases histamine, which people that do mast cell research call this degranulation because the granulations are inside and then the histamine gets released or degranulated. Release of histamine, but also serotonin, heparin, tryptase, thromboxane, which is clot forming, prostaglandin D2, which constricts airways, induces baldness, and platelet activating factor, PAF, which causes atherosclerosis. All of these are activated by mast cells and by the degranulation of mast cells. Mast cells are present in tissues surrounding blood vessels throughout the body. They're also found in the region of epithelial cells that surround nerves. They're most present in regions that interact with the outside world, so the skin, the lungs, the digestive tract, the nose, the mouth, eyelids, right? And they're also present in the genital tissues of both males and females around blood vessels. Next slide. Signs and symptoms of anaphylaxis are very similar to the signs and symptoms that people talk about in POIS. Swelling of the conjunctiva, central nervous system, lightheadedness, confusion, loss of consciousness, headache, anxiety, swelling of the lips, heart or vasculature, fast or slow heart rate, low blood pressure, skin, hives, itchiness, flushing, pelvic pain, right? Gastrointestinal, the exacerbation of IBS, cramps, abdominal pain, loss of bladder control. Next slide. So in anaphylaxis pathogenesis, among the triggers, which you look over on the left, can be latex and seminal fluid. Give me that. Very good. And mediators of all this, either from mast cells or basophiles, if you look at the mediators, you've got all of the things that mast cells release. Histamines, prostaglandins, leukotrienes, right? And the targets for all of these are the skin, the respiratory tract, gastrointestinal tract, the central nervous system, right? And also the idea that you could get visceral responses, dizziness, hypotension, shock, and incontinence. Next slide. So what could contribute to this? Next. The first one I'm going to talk about is sensitized histamine intolerance. Next. Histamine intolerance, also called histaminosis, is an overaccumulation of dietary histamine in the human body. Histamine intolerance is sometimes called an allergy, but the intolerance is technically caused by the gradual accumulation of extracellular histamine due to an imbalance in its breakdown. And it's broken down, as monoamines are broken down by monoamine oxidase, histamine is broken down by diamino oxidase, or DAO. Roughly 1% of the population has histamine intolerance, and of these, 80% are middle-aged, and things come on gradually. In the central nervous system, psychological stress can release histamine, gut bacteria can release histamine, right, or it can convert histidine to histamine. High histamine foods, which is everything that's good, everything we love, contains histamine. You also have degranulators or liberators, so allergens, sulfites, things that are additive to foods, lecithins, right, which you can find in, again, other things that we like to eat: legumes, soy, red beans, cereal grains, seeds, nuts, potatoes, egg whites in large quantities, cocoa. And then you have DAO blockers, so you're blocking the enzyme that breaks histamine down, and the biggest one of these is alcohol. So all the food you like and the drink you like contribute to histamine intolerance. And of course, then there are HNMT blockers, but I'm not going to talk about those. Next. Histamine receptor-related symptoms, right? Because the receptors are inducing or are actually causing a sensitization to occur. And you can see respiratory apparatus, nervous system, gastrointestinal, circulatory, and the skin. The H refers to histamine receptor types, type 1, type 2, type 3, type 4, but you can see the types in these different systems that get activated. And what I'm going to propose is that histamine intolerance comes as a sensitized response to histamine that then becomes too much and induces this collection of symptoms. Next slide. What else could contribute to this? Next. Mast cell activation syndrome, or MSAS. MSAS is a condition in which the person experiences repeated episodes of anaphylaxis, which again includes all the things that people talk about in POIS: expanding blood vessels, itchy skin, swollen skin, mucus buildup, tightened airways, wheezing, headache. The symptoms come on suddenly and without any obvious cause, and is therefore difficult to diagnose. However, high levels of mast cell mediators are expressed during these episodes, which include histamine and cytokines, and you can test for that in the blood. The ICD-10 and 11 actually gave this a code, although the DSM doesn't have it because it's a medical condition, but it's a medical condition that now I would argue is related and is perhaps the cause of things like POIS. Next slide. What causes MCAS? Well, the cause is not yet known, but likely candidates are diet, as I just mentioned, drugs, but especially opioids, and drugs that activate serotonin. And you notice that opioids can activate mast cells, serotonin activates mast cells. Mast cells produce histamine, but they also produce serotonin, which then gets back on. So you've got this positive feedback loop here that makes it worse and worse and worse, like all autoimmune disorders. Stress does this. Proliferation of stimulatory cell surface receptors on mast cells, right? So IgEs, IgGs, toll-like receptors, receptors for stem cell factors, etc. Next slide. How could this work with POIS? Well, again, remember 2 types of onset, one during puberty and with your first experiences of ejaculations and orgasms. The other is an onset later in life that occurs gradually, like autoimmune disorders do. In addition to rapid premature ejaculation in men, and usually the ones that have the primary type also have premature ejaculation, which means that they have a heightened input from the sympathetic nervous system. It's likely that persons with POIS have either histamine intolerance or are developing it, and or they have sensitized MSAS. They may well have lifetime-related issues with allergies, inflammation, stress, gastrointestinal problems, respiratory problems, or cardiovascular issues. When POIS hits, it's felt as something new, when in reality, it's yet another manifestation of either histamine intolerance and or MSAS. Next slide. So here's some analogies to consider. Is vulvodynia a sexual disorder or a pain problem? Is the pain on the roof of your palate when you're eating, say, pineapple, is that an eating disorder, a food allergy, or a pain problem? Let's think of POIS as a straw that breaks the camel's back. You have a number of low-level allergies, inflammation, stress, diet, the drugs that you're taking. You have histamine intolerance or MSAS, which you know you have for some things, but now as this progresses systematically throughout the body and systemically, now ejaculation and orgasm produces an effect like the effect you get that you've had with your irritable bowel syndrome, with your allergies, etc. Next slide. So awareness is important. The histamine release during ejaculation orgasm reaches a critical threshold for fully blown histamine intolerance and or MSAS. Next. So underlying causes to consider, again, history of low-level chronic allergies, including food allergies, inflammation like irritable bowel syndrome, but also inflammation of the skin, headache, prolonged inflammations of cardiovascular systems, diet, drugs, stress. You need to assess the diet, assess what current medications they're on, what their stress reactivity is like, and look for histamine intolerance and MSAS. Next slide. So doing a systematic identification protocol is a really good idea. Take a medical history, right? Do use patient recollections. Are symptoms triggered by eating histamine-rich foods, which, you're on a date, you've taken your date out to a restaurant, you've had wine. Wow, histamine is going up dramatically. Are you taking drugs that liberate histamine or inhibit DAO? Do you have allergies? Are there concomitant diseases? Look for mastocytosis. Check for things like tryptase. Check for food allergies. Check for semen allergies. Do a skin prick test. RAS provocation. Exclude other causes, like if they're taking on opioid medications, monoamine oxidase inhibitors, which can also act as DAO inhibitors, SSRIs, which are now amplifying serotonin and the effect of serotonin then on releasing even more histamine, and do an endoscopy for GI symptoms. If there are more than 2 symptoms of histamine intolerance, then improvement may come with a histamine-free diet. But again, this needs to be tested. You can measure DAO and histamine. You can do a double-blind, placebo-controlled histamine provocation, even in a single individual. Antihistamines, histamine-free diet, mast cell stabilizers, DAO substitutions, these will all help individuals that have this, but it's going to depend on how it's expressed. Next slide. So potential treatments, again, no known cause, so no known empirically based cure. However, men on the POIS Reddit group have tried many potential treatments. And some of these are things that Irwin has kind of alluded to. So for example, H1 antihistamines, H2 antihistamines, sympathomimetic drugs, for example, that activate noradrenaline like pseudoephedrine, phenylephrine, amphetamine derivatives, salbutamol, clonidine, or dopamine, apomorphine and bremelanotide. Anti-leukotrienes, right? Monoleucasts. Again, things that will reduce the leukotriene levels. People try natural products like curcumin, St. John's wort extracts. NSAIDs, okay, including aspirin, can be helpful in reducing inflammation in some patients, while others, unfortunately, can have a dangerous reaction to it because aspirin can also cause histamine release. Niacin, magnesium, supplements for flushing, and the long-term change in diet, reduction in histamine-rich foods, and DAO inhibitors like alcohol. Typically, the people on the POIS Reddit group take these as a pre-pack 30 to 60 minutes before sexual activity to simply reduce the buildup or the impact of the buildup that's going to happen. Next slide. So take-home messages here. POIS is rare. It's a rare sexual disorder that's becoming recognized more and more prevalent in sexual medicine. And as with PGAD, GPD, more and more people are presenting with symptoms that fit the nascent diagnosis for this disorder. Expert opinions for patient care and symptom management do exist, as Irwin suggested, also for anhedonia, but clearly more research and appropriate clinical trials for treatments are needed. So with that, I want to thank you all for your attention, and let's move on to the Q&A.
Thank you so much for your fabulous presentations. I'm sure people will be referencing back to the slides because there's so much information presented, and we thank you for trying to suss out what is yet unknown about these two somewhat rare disorders. So right now, I'd like to go to some of the questions posed by the audience. First of all, I'd like to ask, someone said the previous definition of the ISS panel was sex specific. This new one appears to be unisex. What evidence was considered to back this up? Either of
So,
you gentlemen.
and I'm involved, and Jim is involved
Yep.
also in the ISSWISH consensus panel, and ISSWISH is, of course, dedicated to the study of women's sexual health issues. So, the definition that we're going to propose is obviously dedicated to the group that we're representing. But truth be told, I don't think it's going to be that different in the genders. And the evidence is based on the physiology. Barry Komisarek has done the most research that I've ever aware of in doing fMRIs during orgasm, and all the work that involves the orgasm with its peak of excitation resulting in an inhibition, and then the time before the arousal and the cognition, excitement, and then the resolution is all based on his fMRI work. So there's substantial human evidence. It doesn't even, while there is animal evidence, there is significant human research. So Jim, how would you answer that?
Well, I mean, I think the mechanisms are the same, but you can apply, and people often do apply a male model to female sexual function. Okay. And it's like, well, okay, so you've had an orgasm, now you're in resolution phase, you're in a phase of inhibition of further genital blood flow for a period of time. Well, what causes that inhibition? Barry's work has shown in both males and females that you need inhibition of pain in order to liberate pleasure. Right? Pain and pleasure are very closely related, and they're closely related. They're essentially next door neighbors in the brain. When you look at the midbrain, you've got regions that are associated with pain, regions associated with pleasure. And it's very interesting that these regions are activated when people actually have orgasms. And as Irwin really eloquently showed you, what is that face? What is orgasm face? If you show orgasm face to people on the street and say, what's happening to this individual? The first thing they're going to say is, my God, they're in pain. But they're not in pain. You can see the same thing with a yawn. Is a yawn painful? No, it's pleasurable. That release, muscle tension release, produces this ideal idea of pleasure that also is activating endogenous opioids in the brain, in these pleasure-related centers of the brain, right? And that produces your perception. Now, is a yawn an orgasm? Yes.
Yes.
So an orgasm is not just a sexual thing, but it's this buildup of tension that gets released,
Yeah.
right? A
Just like
sneeze
a
is
sneeze.
the
Yeah.
same kind of thing. Yeah. So I think the definition that we're posing is going to be the same for males, but the dynamics of the interplay, say for women that have a male-like orgasm response where they have one big one and then fall asleep, or for women that have multiple orgasms or have two or three big ones and then have a resolution, that's going to play out differently the way the brain is processing that sensory stimulation relative to males.
Thank you. So another participant asks, is about squirting urine at orgasm. Why does the fluid not smell like urine? Does it still come in quantities even if the bladder is emptied before sex?
This is one of my favorite conversations. I love this conversation. So, I was presenting a lecture to Rose Hartzell's group she's at SDSU, San Diego State University, and the number one question this group wanted to know is, what is squirting? And because many of them have it, they didn't understand it. So, um, um, Yanini is my expert where I go to for squirting. So he's responsible for my knowledge. But Basically, it's a diabetes insipidus state. So there's this release of antidiuretic hormone typically, which prevents you from having dilute urine. It's concentrated. But in diabetes insipidus, there's a blocker of ADH, antidiuretic hormone. So urine is the kidney is making lots and lots of very diluted urine during sexual activity. So as you enter the orgasm phase, you're blocking antidiuretic hormone. Add to that, the sympathetic tone is dramatically increased during sexual activity. Sympathetics block bladder contraction. So there's no ability for the bladder to feel that it's being filled, and there's a lot of dilute urine being made. It doesn't smell like urine. It doesn't taste like urine. It's basically water that's filling the bladder. And then you get this muscle tension and muscle release, and you get a squirt because you now have intravesical, intrabladder pressure greater than the resistance posed by the muscle because now the muscle's relaxed and whoop, it squirts out, which is, by the way, is very pleasurable. Or some people get really embarrassed by it where it's not pleasurable, but if they were taught that it was pleasurable, and they don't mind it. It's not urine per se, because it's not concentrated, but it is urine per se. And then, of course, there's ejaculation. There is a prostate in a woman, and there is activity, just like in men, of stimulation of prostatic tissue during orgasm. So, anyways, orgasm in women, because that's what we're studying, is just one of the most fascinating physiologic events I've ever been involved in. And working with Barry is a true pleasure and treasure, and Jim and everybody else in our group. But I don't know. We need to study this more. It's barely researched.
Yep. Agreed.
Thank you. Thank you. Any other comments, Jim, that you want to make on that subject?
No, other than Barry Komisarek is a true treasure. And I've known Barry for almost 40 years, and he is one of the most amazing intellects.
Thank you. Yay. Okay, another question. Can you have onset of POIS symptoms a day after ejaculation?
So let me start, and then Jim, you take over because it's your talk. But I want to bring out that if you measure dopamine, let's say you have your buildup, you have your climax, you now have the inhibition of muscle tension, and now you're entering this time after orgasm where you're resolving, and you measure the blood prolactin in your body. So it's going to be very high because dopamine is very low. The resolution state is fascinating. There's essentially no oxytocin, noradrenaline, and no dopamine. Yet there's very, very high serotonin. Your lecture said that serotonin could trigger this MCAS of POIS. So the way my brain thinks of POIS is it's a serotonin-induced inability to return back to the baseline pre-arousal state, which I guess you could argue is the MCAS, is what you're saying. So all therapeutic efforts in my office to treat POIS are to change the neurotransmitter balance. Okay, we would increase oxytocin, increase dopamine, increase noradrenaline. We would make every effort to decrease serotonin to get out of this crazy state. Add antihistamines to the soup. And that's how we would do it. So yes, you can get it a day after, but typically it's happening,
Immediately.
at the end of the org. Yeah.
Yeah. Yeah. No, I mean, I can't add anything further to that because that's exactly what's happening. I think what people try to do is reduce the symptoms of it, but the cause, yeah, may well be an enhanced serotonergic activation, right? That then
And
is
you can't get
that,
out of it.
well, exactly, right?
The
Exactly.
perpetual
Exactly.
serotonin.
Well, and again, because there's a perpetual positive feedback,
Yeah.
which in some individuals can last a week, other individuals it lasts a day, for other individuals last an hour, but it's an hour of hell, right? And nobody wants to experience this hour of hell. So what you have are men who in the POIS Reddit group, I mean, I read, these, and they're talking about, oh, I try not to ejaculate. I try not to have an orgasm. but something will happen and then it gets triggered, right? And that
Yeah, it's
something
called
is
going to sleep at night.
is an interaction with their partner, right? So it's like they really don't want, so trying to push it off, right? Very much like men with rapid ejaculation who are trying to not rapidly ejaculate, right? So they try to push it off, push it off, push it off. Unfortunately, that may actually increase, not decrease, the serotonergic effects.
Excellent. Thank you so much. Question, the person with POIS, can that fluctuate with different sexual partners?
That's a really good question too. And this gets back to what Irwin's talking about. And again, the relationship, we think of orgasm as a static state, but orgasm relies on arousal, right? Especially the activation of sympathetic arousal, et cetera, at least at the level of the genitals. But as Irwin pointed out, you've got sympathetic and parasympathetic arousals happening all over the body, right? Orgasm relies on arousal. Orgasm without arousal can happen. Arousal without orgasm can happen. So the question is, how does that happen with different partners? And so it does happen in the POIS Reddit group. I've read it, where they say, well, this happened with, my current partner, but it hadn't happened before. And then, or, my current partner and I broke up, or my partner and I broke up. Now I have a different partner, and it doesn't happen the way it was happening before. But I would argue, is that level of arousal different that the orgasm is resting on? I mean, we like to say that, oh, the more the arousal, the better the orgasm. But it can be the more the arousal, the worse the POIS symptoms.
I just want to say one thing. It's not addressing your question. It's addressing something you said in your thing, just because it activated my brain. You said you can have arousal without orgasm and orgasm without arousal. When you have arousal without orgasm, that's what we call female orgasmic. Well,
Yeah,
in the
yeah, yeah.
consensus panel, it's the FOD.
That's right. That's right.
It's failure to excite, and we're getting really good at treating that better, by the way. But arousal with orgasm is very frustrating. Can't get to the other side.
Yeah.
Then I have several more questions. So, how does your work now relate to the research on orgasm by Masters and Johnson? And is there something more that could be learned by reviewing their work?
Linda, you should answer that. You were part of that group.
Yes, I was. Not on the research side, however. I was on the clinical side of that. And there are several things about their model that have been changed. One is the addition of desire difficulties, which they did not examine or note. That was Helen Singer Kaplan that later came to that. The other thing that we've learned since their original research is the model for their orgasmic response or arousal response left out female sexuality, which can result in multiple orgasms. So it isn't this straight line experience that they initially reported. So there have been many changes, but I don't know much about how your research on the human body and what happens during arousal and orgasm relates to theirs. I imagine it was sort of the baseline model, and additional research with additional mechanisms for measurement has increased our understanding and modified a lot of their initial research. What are your responses?
I'm going to say that the Kamazarek fMRI data was very influential for me getting a better clinical understanding of the management of specifically female orgasmic dysfunction, but obviously male orgasmic dysfunction the same. The requirement to have this combination of excitation inhibition was novel to me. And the concept that you can raise sympathetic and not inhibit parasympathetic, the concept that you can raise both of those at the same time in conjunction with oxytocin and serotonin, all of those things happen all at once. And this idea of amazing brain activity that gets you to basically every part of the brain. Every Brodmann center was increased. It's kind of bizarrely amazing. Was totally fascinating to me. So, Masters and Johnson, they did it in a clinical context, and Barry and Jim and with the animal models and the neurotransmitters are doing it more at a better understanding of what's actually happening in the brain. And when we parse all that out and we get better clinical therapeutic options, like with psychedelics, that will play with the endocannabinoids and the opioids in the brain, then we're going to be able to really be able to manage patients better. That is my true belief. We're just touching on the surface. Again, where we were with PGAD in the early 2000s, where we're now much better. We now have region-based strategies for management. We don't yet have this construct for orgasm. And just the concept that we're dividing orgasm by events that happen before orgasm or events that happen after orgasm or events that happen during orgasm, just even the concept that we're dividing the dysfunctions by the different parts of the process is kind of exciting and new.
And another thing too, that you've got a spinal reflex and you've got your brain's perception, your conscious perception of it, right? And even those two things are a bit different in the sense that you have, you know, uh, Kevin McKenna, for example, made a really good point of saying, okay, we have something we call climax and we have something called orgasm. Are they the same thing? We've been using the terms interchangeably, but Kevin actually made the point that maybe climax, that feeling of muscle tension, pelvic floor muscle tension release, right, is what we really call climax. And that orgasm is a conscious perception of the pleasure associated with that. And the whole, then, as Irwin was saying, the build up to that point and then the breakdown after that point, right? The conscious perception of that. And I think that's something really important to understand, that you can have a percent, like, for example, I remember Christopher Reeve, the guy that played Superman, right, who was involved in a horse accident which left him paralyzed. He gave a talk at the Society for Neuroscience meeting, I think it was 2012, in which he said that he could have a perception. Because remember, he made 3 kids after this. Yeah. And he and his wife would have sex, and he had the perception when he could watch himself do this, he could have a perception that when he ejaculated, he had an orgasm. Now that's impossible given where the actual complete nerve transaction occurred in his spinal cord. But it wasn't, because his brain has kind of motor memory of this, right? So his brain has a memory of what an orgasm is. He would see this, he could feel a buildup of tension, he could feel a release of tension, seeing his own ejaculation or sensing his ejaculation or his wife reacting to his ejaculation. But he was sensing that. As soon as he closed his eyes, it went away. Kind of like phantom limb pain, but the opposite. Yeah.
Christopher Reeves still had his vagus nerve intact.
And well, that's exactly true.
Barry will tell you
I
all of
was going to
that
get to that.
happened.
I was going to get to that, right? So you have orgasm is a very multifaceted thing. And what I'm so excited about with this group and with everything that we're doing studying orgasm, I mean, we've known more about swallowing and digestion than we've known about orgasm, something we do with, that our species does, that everyone in our species has some semblance of an understanding of. Now, 21st century is when we begin to really, truly delve into it. It's exciting days.
Yes. Thank you. So as there are several related questions related to histamines. And someone writes, thanks so much. So helpful regarding POIS. Has the evidence coalesced around histamine related causes of POIS? I know there were other theories in the past related to prolactin surge, lack of progesterone, and so on. Are these considered off the table now, or am I missing the link between these and histamine?
Yeah, the link is really tenuous at this point. I think because the way the symptoms are manifesting look more like histamine intolerance or MSAS. I think that's one of the reasons why that's kind of come to the foreground. But I wouldn't take anything off the table at this point because everything needs to be looked at, and nothing has been looked at yet systematically.
Well, the one comment I want to make is somehow the word semen allergy as the predominant basis for this is, I would like take that maybe not off the table, but close to off the table. I mean, I like the idea of the MSAS and the serotonin increase activating that, but I don't think it has anything to do with semen allergy. Just to state that publicly,
Yeah,
I just because we see POIS in women who aren't who are self-stimulating.
yeah,
There's no access to the semen context there.
yeah. No postcoital sneeze.
Well, that's another orgasm. It's a sneeze.
Yes. So another question, problems with orgasm after nerve-sparing prostatectomy. Is there advice for these men from our experts?
Well, could you repeat that after this is
Difficult-
orgasmic
Prostatectomy.
dysfunction?
Difficulty with orgasm. I imagine we're talking about the pleasure experience after
So,
nerve-sparing
no,
prostate.
that's so interesting. There's clearly, the prostate is the source of the fluid, so there's clearly an ejaculation change.
Deficit.
But it's really commonly reported that the pleasure of orgasm isn't changed post-radical prostatectomy. So for this, it's more unusual to have a change in orgasm pleasure than one would think. And I'm going to just say it's that there's other things going on here, and it's not necessarily directly related to prostate. It's or to prostatectomy. It's kind of like men can have lack of pleasure who have never had a prostatectomy at all, and I think that's partly in play here. But again, as we are seeing, in an expert opinion, clinical successes with anhedonia management by those 8 categories on that slide. So CNS activation, increasing dopamine, increasing oxytocin, lowering serotonin, increasing testosterone. Those strategies, I would definitely take a role in that with the prostate person. I actually have to get to the office soon, so I have to get off, and maybe one more question, and then I have to go.
Sure.
Okay. One more question. How does low or absent pleasure during arousal relate to orgasmic anhedonia? Are these conditions often concomitant?
Well, that's a great question because the pleasure that the anhedonia is discussing is the release of muscle tension primarily. Yet there's pleasure in arousal, but that's a separate pleasure. You could please your partner, and you can watch your partner be happy, and that's a pleasure. It's the construct that we're trying to develop in the anhedonic state is a different pleasure than that achieved by being intimate, I guess would be another way to think of it. The pleasure, the satiety and contentment that drives everyone to want to have orgasm is this amazing build up, sympathetic, parasympathetic activation, oxytocinergic, serotonin, everything's happening. And then your muscle tension goes to incredible tension. And that sudden climax release, that's the true pleasure that we're talking about. Muscle weightlifters, they lift all these things and then they drop the weight. They feel like $1,000,000 after that.
Mm.
That's different than going to the gym and feeling good about getting out of the office and getting rid of the stresses. That's a different kind of a pleasure. Hope I made it clear, but it's different.
One way I would put it, Irwin, is that we have both appetitive pleasure and consummatory pleasure. Now, this is speaking as a neurobiologist here, but think of the pleasure that you have tasting that first morsel of food. It's your birthday, you're going to your favorite restaurant, you've not eaten a thing all day because you're going to have your favorite meal, and you taste that first morsel of food, and it's so delicious because it's your favorite food. That's pleasure. But also imagine that now you've eaten your meal, you feel really good, but that's satiety-related pleasure. And orgasm comes in this more satiety or consummatory like state relative to that first bite of food, which could be the electricity of that first kiss, that you're experiencing with someone. Yeah, that's pleasurable. And it's a release of tension in a way, but this is now a different kind of release of tension, right?
That's brilliant. What you
a
just
whole
said
body
was
release of
amazingly
tension.
brilliant.
Thanks,
I
man.
love working with you, Jim.
I love working with you
just
too.
awesome.
Thank
Okay,
you.
Linda, I have to get off, but
All right.
listen, I want to thank ISSM. I want to thank everybody involved. I want to thank Jim and Linda, Siobhan. Thank you all. And we need to do a lot more research in this area.
I want to thank everybody too for your attention and for all your questions. And if you have further questions, please, you can send emails to me and Irwin. I have no problem answering your questions.
Yeah, dr.irwingoldstein@gmail.com is mine.
jim.pfaus@gmail.com is mine.
Thank you so
Thank
much.
you so much, and thank you, Lillian, for helping us with video and audio.
Thank
Thanks,
you,
everyone.
Lillian.
Thanks, everyone.
Time.